Metformin is the most prescribed diabetes drug in the world, more than 90 million prescriptions every year in the United States alone. It has been in use for over 6 decades. Most doctors consider it so safe, so well understood, so unremarkable that the conversation about it at the prescription counter lasts about 45 seconds. Here is your prescription. Take it with food. See you in 3 months. But here is what almost no one tells you, and what the research published in the last 5 years has made impossible to ignore. After the age of 60, the way your body handles metformin changes. The way your kidneys process it changes. The nutrient it depletes, one that is essential for the health of every nerve in your body, depletes faster. And the risk associated with that depletion is one of the most underdiagnosed conditions in senior medicine today. If you are over 60 and taking metformin right now, or if someone you love is, this video is the one to watch before the next dose. I am going to tell you exactly what the research shows, what changes after 60, what to watch for, and what the conversation with your doctor should include that it almost certainly does not right now. I review published clinical research on senior health, specifically the findings that do not make it from the journal page to the exam room. In this category, the gap between what we know and what patients are told is one of the widest I have encountered. Stay with me through the end. The section on what to ask your doctor is the most important part of this video. It is also the shortest. Write it down. There is one number your doctor should be checking every time your metformin prescription is renewed. Most are not checking it. It requires one additional line on a routine blood panel. And without it, a deficiency that looks exactly like early dementia, foggy thinking, balance problems, tingling in the hands and feet, can go undetected for years. We will get to that number. First, let me give you the foundation. Metformin works primarily in the liver. It activates an enzyme called AMPK, adenosine monophosphate activated protein kinase, which you can think of as the cell's energy sensor. When AMPK is activated, it signals the liver to produce less glucose overnight. For someone with type 2 diabetes, whose liver is producing too much glucose even when it should be resting, this is enormously useful. Metformin also improves the sensitivity of muscle and fat cells to insulin, making the insulin your pancreas produces more effective at moving glucose out of the bloodstream and into cells where it belongs. It does not cause low blood sugar on its own the way some other diabetes drugs do. It does not cause weight gain. It has a 60-year safety record. The reasons it is the first drug most doctors reach for in type 2 diabetes are real and well supported. Now, here is where the age equation changes. After 60, kidney function naturally declines. Not because of disease necessarily, just because of age. The filtration rate, the speed at which your kidneys clean your blood, drops by roughly 1% per year starting in your mid-40s. By the time you are 70, even a person with no kidney disease may be operating at 50 to 65% of the kidney capacity they had at 40. This matters for metformin in a very direct way. Metformin is eliminated almost entirely by the kidneys. It does not get processed by the liver the way many drugs do. It passes through the body and exits through the urine. When kidney function is high, that process is fast and efficient. When kidney function is reduced, as it naturally is after 60, metformin clears more slowly. When metformin clears slowly, it accumulates. And when it accumulates beyond a certain threshold, it creates a risk that most patients on metformin have never been warned about: lactic acidosis. Lactic acidosis is a buildup of lactic acid in the bloodstream. Metformin, when it accumulates in the body, interferes with mitochondrial function in a way that shifts cellular energy production toward a pathway that generates lactic acid as a byproduct. In a healthy kidney that clears metformin efficiently, this effect is minimal. In a 72-year-old kidney operating at 55% capacity, the accumulation risk is meaningfully higher. Symptoms of lactic acidosis can be subtle at first: unusual fatigue, muscle weakness, difficulty breathing, nausea, stomach discomfort. They are also symptoms that many seniors and their physicians attribute to aging, to other conditions, to other medications. The diagnosis gets missed. A 2022 review in Diabetes Care analyzed metformin-associated lactic acidosis cases and found that the majority occurred in patients over 65 with reduced kidney function, and that in most of those cases, the patient's kidney function had not been reviewed within the 6 months prior to the event. The current FDA guidance is clear. Metformin is contraindicated, meaning it should not be used when kidney filtration rate falls below 30. It requires dose adjustment when filtration falls below 45, and kidney function should be reviewed at least annually, ideally every 6 months, in patients over 65 on metformin. How many patients actually have that review happening on that schedule? A 2020 study in the Journal of the American Geriatric Society found that among adults over 65 on metformin with reduced kidney function, nearly 40% were on doses higher than the current guidelines recommend for their level of kidney function. Nearly 40%. Not because their doctors are negligent, because the review is not built into the system the way it should be. The first thing to do after watching this video, find out when your kidney function was last measured. If it has been more than 6 months and you are over 60 and on metformin, ask your doctor to run a basic metabolic panel with creatinine and GFR, glomerular filtration rate, 1 blood draw. That one number tells you whether your current metformin dose is still appropriate for your current kidney function. Now we get to the finding that the research has been accumulating for 30 years, and that still does not reliably make it into the standard metformin conversation. Metformin depletes vitamin B12, not as a rare side effect, not in a small subset of patients. In studies tracking metformin users over time, B12 deficiency or subclinical B12 insufficiency is found in 10 to 30% of long-term users. Some studies in older populations with longer duration of use put the number higher. The mechanism is specific and well understood. Metformin interferes with the absorption of vitamin B12 in the small intestine. Normally, B12 binds to a protein called intrinsic factor and is absorbed in the last section of the small intestine, the ileum. Metformin appears to interfere with the calcium-dependent process that allows this absorption to occur. Calcium supplementation has been shown in some studies to partially restore B12 absorption in metformin users, but here is why this is especially dangerous after 60. Vitamin B12 absorption naturally declines with age even without metformin. The stomach produces less acid. Less acid means less of a protein called pepsin. Less pepsin means less efficient release of B12 from food. Add metformin's interference with the ileal absorption mechanism on top of that age-related decline, and you have two processes working simultaneously to drain B12 from the body. And B12 depletion in an older body does not announce itself clearly. It builds slowly. Over months, sometimes years. Consider what happens inside the nerve fibers when B12 falls below the threshold the body needs. B12 is essential for myelin production. Myelin is the insulating sheath that wraps around nerve fibers. Think of it as the plastic coating on an electrical wire. When B12 is adequate, myelin is maintained. Nerve signals travel fast and clean. When B12 drops, myelin degrades. The insulation thins. Nerve signals slow. Misfire, drop. The symptoms that result are easily misread. Tingling or numbness in the hands and feet, often attributed to diabetic neuropathy when it may be B12 deficiency from the drug being used to treat the diabetes. Balance problems, attributed to inner ear issues or general aging. Fatigue, attributed to the diabetes itself or to aging. Cognitive slowing, memory lapses, difficulty finding words, attributed to early dementia. A 2019 study in the Annals of Internal Medicine followed metformin users over a 5-year period and found that B12 levels declined progressively with duration of use. More importantly, participants with the lowest B12 levels had measurably higher rates of peripheral neuropathy, nerve damage, than those with adequate B12. And critically, among participants whose neuropathy was later found to correlate with B12 deficiency rather than diabetic nerve damage, the distinction changed the treatment entirely. Diabetic neuropathy is treated by controlling blood sugar. B12 deficiency neuropathy is treated by restoring B12. They require different interventions. And if no one checks the B12, the wrong treatment gets applied, or no treatment gets applied at all. Here's what makes this particularly difficult. Standard blood tests measure total serum B12. But total serum B12 can look normal, while functional B12 Ta, the amount actually available to nerve cells, is low. The more sensitive markers are methylmalonic acid and homocysteine. When B12 is truly adequate at the cellular level, methylmalonic acid is low. When B12 is functionally deficient, methylmalonic acid rises, even if the total serum B12 number looks acceptable. Most routine panels do not include methylmalonic acid. You have to ask for it, and most patients on metformin are never told to ask. There is a third layer to the metformin conversation that is newer and more nuanced, and I want to present it carefully because the science is still developing. In the last decade, metformin has attracted significant interest from longevity researchers. The AMPK activation it produces, the same mechanism that lowers glucose production in the liver, also triggers a cellular cleanup process called autophagy. Autophagy is the body's system for identifying damaged cellular components, breaking them down, and recycling them. It is one of the most important processes in cellular maintenance and healthy aging. Metformin's activation of AMPK appears in laboratory and animal models to enhance autophagy. Some researchers have proposed that this might make metformin a general anti-aging intervention, not just a diabetes drug. The TAME trial, Targeting Aging with Metformin, is an ongoing large-scale study designed to test this hypothesis in non-diabetic adults. This is genuinely interesting science. But here's the counterpoint that is less often discussed. The same AMPK activation that may enhance autophagy also partially inhibits a pathway called mTOR, mammalian target of rapamycin. mTOR is involved in muscle protein synthesis. Chronic inhibition of mTOR, particularly in older adults who are already experiencing age-related muscle loss, sarcopenia, may work against the very thing that keeps seniors functional and independent: muscle mass. A 2021 study in the Journal of Gerontology found that among adults over 65 participating in a structured exercise program, those taking metformin showed significantly smaller gains in muscle mass and strength compared to a matched group not taking metformin, despite performing the same exercise. The metformin group's anabolic response to exercise was blunted. For a 65-year-old trying to maintain muscle mass and physical independence, this is not a trivial finding. This does not mean metformin should be stopped. For someone with type 2 diabetes, the blood sugar control it provides protects the kidneys, the eyes, the heart, and the nerves over the long term. That protection is real and significant. But for someone approaching the boundary of whether metformin is necessary, someone whose blood sugar is well controlled, who has made meaningful lifestyle changes, whose doctor might consider whether the drug is still needed at the current dose, this muscle loss finding adds a dimension to that conversation that rarely gets raised. Think about what this accumulation of evidence looks like in a real life. A man, call him Gerald, is 71 years old, retired, active, walks every morning. He has been on metformin for 9 years, prescribed when his A1C was 7.4. His current A1C is 6.8, well controlled. Over the past 2 years, his wife has noticed he moves more carefully going downstairs. He has mentioned that his feet sometimes feel strange, not painful, just different, slightly numb at the tips. Last month, he had a moment in the kitchen, reached for the counter because the room seemed to tilt. His doctor attributed the balance issue to inner ear changes. His foot symptoms were documented as early diabetic peripheral neuropathy. His metformin prescription was renewed without change. Nobody checked his B12, nobody checked methylmalonic acid, nobody reviewed whether his kidney function, last tested 14 months ago, was still in the range appropriate for his current metformin dose. Gerald's presentation is not unusual, it is in fact typical. The symptoms of B12 deficiency in a metformin-using diabetic over 70 look almost identical to the symptoms of diabetic neuropathy. Without the blood test, the distinction is invisible. I want to say this as clearly as I can because it matters. Do not stop metformin on your own. Do not skip doses. Do not reduce your dose without your doctor's guidance. Uncontrolled blood sugar in type 2 diabetes causes real, serious, irreversible damage to the kidneys, to the eyes, to the cardiovascular system, to the nerves. Metformin prevents that damage. For most people taking it, the benefit of that protection is substantial. What this video is giving you is not a reason to stop. It is a reason to be informed. And the 3 things you take to your next appointment are simple. 1. Ask when your GFR, your glomerular filtration rate, was last measured and whether your current metformin dose is appropriate for that number. If it has been more than 6 months, ask for the test to be run. 2. Ask to have your B12 checked, and specifically ask whether methylmalonic acid can be included on the panel. If your doctor is not familiar with the metformin B12 connection, that is a reasonable moment to mention that the American Diabetes Association updated its standards of medical care in 2022 to include a recommendation for periodic B12 monitoring in long-term metformin users. 3. If you are exercising regularly, which you should be, ask whether your current metformin dose and your muscle health are being considered together, especially if you have noticed changes in strength or recovery that you did not expect. 3 questions. 1 appointment. The answers may change nothing, or they may change everything. Leave me a comment below. How long have you been on metformin? And has your doctor ever specifically mentioned either the kidney monitoring schedule or the B12 depletion to you? I want to know how many people have had this conversation and how many have not. The next video covers something that sits right next to this one, the blood sugar medication that is being added to metformin in millions of prescriptions right now, and the side effect that almost no one is warned about in the first 90 days. That one is next. The information in this video is educational and based on published research. It is not personal medical advice. Never stop, reduce, or modify any prescription medication without speaking to your doctor or pharmacist first.